Hello, hello. Welcome, I guess, to the week three PowerPoint in preparation for the CVA lab. Really looking forward to it. If you remember, I'm recording the slides so that we can maximize our time in lab working on transfers with individuals who've had a stroke as well as dressing techniques for individuals who've had a stroke, specifically hemiplegia, as well as cranial nerve testing and subluxation management. So hopefully, not hopefully, but I'm sure that you've done your readings. Please go and look at the other videos that I've posted on transfers. I specifically spent a lot of time trying to find videos that had stroke survivors at different levels, just so you would get a good visual representation of someone who's had a stroke and what transfers would look like. Now, I could not find a video with the perfect transfer in it. So you'll see the video that has the maximal assistance transfer. They're not using a gait belt. Um, we want to make sure that you always use a gait belt, so keep that in mind. And I'm sure you'll find some other things in the videos that you question or maybe you would do differently, and that's perfect because they are definitely not representations of the perfect transfer. So don't forget to review OT Toolkit handouts before you come to class as well. So let's get started with the slides. And I know you've had your second lecture with Dr. Offeld on strokes. So in stroke recovery, I really wanted to kind of bring this together. And I know she's already talked about this, but just to kind of set the tone for lab on Wednesday, keeping in mind our treatment approaches. They're actually going to be two different treatment approaches, and this is going to be true in a lot of cases with most diagnoses and conditions. But in the early stages of recovery, we definitely want to use the establish restore intervention approach, which is remediation and restoration. We also want to kind of think about as treatment progresses that we're going to use that modify, the compensation and adaptation intervention approach. I don't want to make it too confusing, but a lot of times you can use your compensatory and adaptive strategies even to promote remediation and restoration. So we'll talk more about that as we go through the slides and also during the lab. Keep in mind that when we're using a establish restore approach, that remediation and restoration, what we're really trying to facilitate is neuroplasticity. And so in the content of stroke recovery, neuroplasticity really refers to the brain's remarkable ability to create and form new neural connections and pathways after a stroke. And so we want to go even maybe a little step further in looking at cortical reorganization. And so this is where we're actually going to hopefully maybe recruit some other areas of the brain to kind of take over those functions. So when we're talking to our clients, and kind of back to cortical reorganization, we're looking at kind of remapping functions. And so we're kind of trying to shift, like we said, some of those functions into other brain areas. When we are relating to our clients and kind of explaining the process, I have found that it's extremely important to, one, be able to explain what a stroke is, what has occurred. Believe it or not, in home health, I would work with lots of clients who were treated in the ICU in acute care, then they transitioned over either to long term acute care, or they went to inpatient rehab, or they went to skilled nursing, or maybe a little bit of all of that. They may have went to inpatient rehab after acute care and then went to skilled nursing. So I was not typically the first occupational therapy practitioner that they worked with. And a lot of times I would ask them, do you understand what a stroke is? Do you understand what occurred? And a lot of times family members wouldn't understand either. So in some cases, the client maybe just didn't remember that education that was provided, but the family member did. Sometimes no one remembered that education. So you want to be able to explain, and that's why, Dr. Offeld spent so much time and she did an amazing job going over the causes of stroke. You have your ischemic, right, and your hemorrhagic, or your embolic. So just kind of thinking about those. And then also, you're going to need to explain what the purpose of your therapy is. And explaining that we're not actually making muscle stronger, right? It's not the strength of the muscle necessarily, it's the connection, of that pathway, trying to get that motor movement elicited. And so you're going to want to explain that in terms that clients understand. And so I would use words like rewire because a lot of times that's an easy concept to understand. So just kind of keep that in mind. That's really kind of the goal with remediation and restoration. The book, your textbook went over different approaches, and Dr. Eifeld has covered different approaches, NDT, uh, RUDE, right? But your book mentioned task-oriented approaches, and I really wanted to kind of touch on those. I know also there was a discussion about constraint-induced movement therapy, which the research shows there are benefits. We also talked about the challenges being you really can't humanely restrain someone's unaffected extremity for long periods of time. There are a lot of challenges there. And also, there was some mention of mirror therapy, which is part of a larger uh, graded motor imagery. Sorry, it took me a second. Um, which that protocol has been shown to be effective in working with those who've had strokes as well. So I wanted to kind of talk about task-oriented approaches because it really falls into our lab that we're going to do. And so that's why I wanted to spend some time on it. So, task oriented approaches are where you use functional activities as the therapeutic change agent, which in occupational therapy, we've talked about that a lot. We use occupation, the occupation itself, as a therapeutic change agent. So, in this instance, it's functional activities, which are almost always occupations. And so, we're going to use those to create opportunities to practice those outside of regular therapy sessions as well as during the therapy session. And then, really looking at the foundation or basis of these interventions is that they work to improve occupational performance when motor impairment is impacted after stroke. And we've talked about the benefits of especially ADLs, these are familiar activities. Um, it's a lot easier for an individual who may have aphasia, right? They might have expressive aphasia. They may not understand, or I'm sorry, they may have a receptive aphasia. They may not understand the commands that you're giving them. And if they have expressive aphasia, they can't tell you that they don't understand. And so sometimes it's very difficult to learn these new exercises or these new techniques that we're trying to encourage someone who has had a stroke to carry out. And so, functional activities, specifically ADLs, are really great opportunities to use familiar activities that the client may really understand. When you pull out a shirt, they're going to understand that. When you point to the edge of the bed, they're going to most likely understand that we're going to move to the edge of the bed. You put a wheelchair in front of a bed and you pack the wheelchair, a lot of times they understand that we're going to the wheelchair and it all makes sense. And all of these activities, because they're occupations, have meaning. And the research actually shows that that is one of the reasons that task oriented approaches are effective. And so, common themes in the studies that there was a systematic review that Pedretti, your text, mentioned, and there were common themes of effective task oriented approach interventions that they found. They were goal directed, they were individualized. So sometimes when you use pegs and other things like that, the goal isn't always clear for the client. Getting dressed, usually the goal is clear. Individualized, making sure it has meaning to the client. And then the third thing was promote repetition of task related or task specific movements. So, what we know in neural recovery is that repetition is key. Um, some movements, they're saying that we actually need to engage in 50 repetitions a day in order to really create those new movement patterns and those new pathways. So we're probably not going to get dressed 50 times a day, but just thinking about how important it is to have the client go through these things repetitively. So it's okay to do a transfer or to, something like that several times in one session because repetition is key, but then you want to kind of think about consistency day after day after day as well. So let's look at adaptive dressing and positioning for someone who has had a CVA. And looking at our different approaches, you have handouts in the lesson section for you to refer back to, and it goes through step by step instructions. So, just thinking about dressing when you're using a hemiplegic dressing strategy it's kind of easy. You're always going to don, DONN, so put on the affected side first, and you're always going to doff, DOFF, the affected side last. And so that's just a really simple way to remember it. There's a lot of steps in between. Go ahead and refer to your handouts. We're going to do a demonstration in lab, and then you'll have time to practice as well. Uh, and those are your OT toolkit pages. Really want you to kind of consider different levels of assistance, but not just different levels of assistance when you're looking through those. You also want to consider different abilities. So, an individual who is not able to, who has expressive aphasia, you might have to use a lot more visual cues and prompts and maybe even directions. And if someone has a visual impairment, then the setup and the strategies are going to be different because they may not be able to identify the shirt, or if they do, you might see that they turn it the wrong way and they try to put their head in a sleeve and things like that. So, keeping in mind that you're going to have this basis, right, of a strategy, but then you're going to need to modify your approach for your client's ability. And again, uh, looking at your toolkit pages for apraxia and splinting, and then there's the video that's in this specific slide for OT Mary, and she goes over in a little bit more detail the ideational and ideomotor apraxias. So for your assessment, again, these are in the lesson section. We have gone over the Barthel. Remember, we did that last semester. Now, the River Mead is new. We didn't actually do the River Mead. And so you're going to want to review that. It's a pretty straightforward scoring system, 0 or 1. Um, they have to be able to complete the task independently to actually score a 1. And for upper extremity at 3 zeros, that's when you stop. But the lower extremity is different. You actually try to carry out all of those tasks. And double check me on that. That's all from memory. And so looking at bed mobility, again, I put in several videos that have individuals who have had a stroke carrying out bed mobility. We're really kind of focusing on hemiplegia. That is one of the more common effects of a CVA that we treat in occupational therapy. So, when we're working with someone with hemiplegia and we're going, say, side lying onto the weaker side to sitting, so that means they're lying on the affected side, that weaker side, and we're trying to go up to sitting. So, you're going to use the stronger leg to help the weaker leg off of the edge of the bed. And in your handouts, we actually start with supine over to sit at the edge of the bed. Um, so what you want to kind of keep in mind is you're going to typically utilize the stronger or the unaffected leg to roll toward that affected side. So that's why we're going from affected side to sitting at the edge of the bed. Um, and so you're going to encourage the client to be able to scoot their legs off the edge of the bed using the stronger one to help the weaker leg. You might have to do this yourself if it's a max assist strategy or process. And then you're going to have them press down into the bed with the stronger hand. And keep in mind, if they're on the weaker side, they're crossing the midline and they're going to push like this. And again, we're going to demonstrate this in lab. So going supine to side lying on the stronger side. So that means we're going to side lie. We're just going to say that my left side's my weaker side, right side is the stronger side. You're going to flex the stronger hip and knee, and you might even have to slip uh, that stronger leg or foot under the weaker leg. You're going to use the stronger hand to grasp the weaker hand or forearm. So you're going to maybe have to guide this process, right? The end goal is the client ends up understanding this process and can do it on their own. Then you're going to lower the flex leg to the side while bringing upper extremities across the body, right? And push into bed with the foot to complete the roll. And we'll demonstrate that in lab. It's a little hard for me to demonstrate it in sitting. And then side lying on the stronger side to sitting. So we're going to be on this side. This is my stronger side. You're going to slide that stronger foot under the weaker ankle. Bring both legs to the edge of the bed, just like before. And then you're going to abduct the stronger extremity and push the torso in these quick bursts, right? So you're going to be at the side and you're going to try to push. So sitting to side lying, you're going to slide the stronger foot under the weaker ankle, and then you're going to lower your upper body into side lying. So you don't want them to go backwards. We're trying to go to the side because we have more control. This really is easier if you're going to the weaker side, to lie on the weaker side, because you can use this stronger arm to kind of brace and lower. But it can be done to the other side as well. And then you're going to lift both legs onto the bed. So, and I know this seems a little difficult just off of a slide, but we're going to practice all of this in lab, I promise. And make sure and watch those videos. So, transferring a client with who's had a CVA, setting up the environment. This is the same. I know you guys went over transfers in task analysis. You are going to set up the environment the same. Always looking at safety. You're always going to make sure that whatever surface you're transferring to is stable. So if it's a wheelchair, the brakes need to be locked. If it's, a standard chair, you need to make sure it's not going to move. Is it, braced against the wall? All of those things. If it's a bed, if you're transferring to the bed, is the hospital bed locked? Anything like that. You're always going to have a gait belt on no matter what. And then making sure that the client has appropriate footwear and making sure you have appropriate footwear. And in both cases, that would be non skid footwear. Um, in positioning the client really needs to be with feet flat on the floor. They need to be at the edge of the seating surface, as close to the edge as safe, um, because in doing a normal transfer, you really need that bottom to go over your feet. One of the things I tell everyone when I am assisting them with the transfer and telling, any students I have for clinicals, and I used to teach CNA classes. I used to teach them transfers, and then at the hospital we had to rotate and train all new staff in transfers. And a really easy thing to think about is wherever your bottom goes, the rest of you has to go. There's no way around that. Wherever your bottom is, the rest of you will be. And so just kind of thinking of that, that's it's usually your center of gravity, but that is what you're the most worried about is where is that bottom and making sure that bottom is going to stay on the surface. And so when you're transferring, you want your bottom as close to your feet as possible so that the work of getting that bottom over the feet, over that base of support is minimized. And then always consider what direction you want to complete the transfer. Are you going to go toward the involved side or toward the uninvolved side? What I'm going to say is that most videos, most instruction instructs clients and caregivers to go to the strong side. That's typically a safer transfer. And so most of the time transfers start in that manner, going to the strong side. You, as the OT, will probably, as treatment progresses, be facilitating transfers to the affected side, to the involved side. Because you're trying to, be therapeutic. You're going to be working toward attention to this side. It's very therapeutic for a client to start looking over to the involved side, to move to the involved side. It recruits the involved side into the movement. And so, therapeutically, when you're with the client, you may be transferring to the involved side and encouraging everyone else to transfer when you're not there to the uninvolved side. So the transfer occurs once the client is in that ready position, feet flat on the floor, spread apart so that there's a good base of support. Client is stable, they're scooted forward as far as they can be, and you're always going to have the client try to push up from the surface. This is extremely important. You don't want them to get in the habit of a pull. You want them to push because we're trying to work toward eventually them being able to do that themselves. If their affected extremity is able to participate in that or be safe and stable, if there's a sublux, usually not, but if they're able to use the affected arm, even if it's safe for it just to be on the bed, we want to encourage that. And so once you're in standing, the client should reach toward the transfer surface. And just some considerations, you are going to support the upper extremity that's affected with a sling only for the transfer. If there's a subluxation, you can also support that arm because really what we're trying to do is prevent gravity from continuing to pull that humeral head down. So sometimes just putting their hand in their own pocket or in the gait belt, depending on the transfer and what other assistance I might be providing, I might actually kind of position that arm so I'm supporting underneath the elbow to prevent that. But keep in mind, slings provide a lot of safety and prevent that upper extremity, especially if it's flaccid, from being injured further. But slings are not necessarily indicated for prolonged use. Never ever pull on the upper extremity, not just the affected, but the non-affected as well. Um, you guys understand anatomy, you understand the shoulder girdle and that joint, and it's not extremely stable, right? It's not like a hip ball and socket. So we don't ever want to pull on the arms to provide support. And then block the involved knee to reduce falls. You're going to see that a lot. I did want to let you know most clients do not like that. A lot of times it feels uncomfortable. Sometimes it might even be a little bit painful. But it's very, very important that you be able to block the knee because you are creating that knee extension that allows them to weight bear through that extremity. So keep in mind that they may not like it, and you want to definitely make sure you're not injuring them, but also it's really important. And as I've progressed through my career, I have really been able to kind of figure out how to block that knee without really forcing into it too much. I can actually kind of block it a little bit without just knee to knee contact. Now, an assisted pivot transfer, we're going to continue that. Once we're in that ready position, we've scooted the hips forward. You'll see in that video of the maximal assist that you actually help from behind the hips and push one forward at a time. That works so well, and you're alternating those weight shifts. Ensuring that the feet are back, the inner foot is slightly forward, trunk flex. You always tell them nose over toes, hands are on the armrest or the edge of the bed. And so we're seeing that, and you see kind of that knee block in that picture. You see the knee block here. So the clinician's back is straight. That's really important. Clinician is hips are flexed, knees are flexed, wide base of support. Inner foot is slightly posterior, and there's a grip on the gait belt. Blocking the knees, you're going to create that extension moment to counteract that flexion moment or flexion movement at the patient's hips and knees. Um, and this, so keep in mind that when you're assisting with a transfer, that it's okay to get help, and it's also okay for knee blocking to use one knee to their knee, or two, right, of your knees to their one knee, or both of your knees to both of their knees. So there's the one-to-one knee block. That's the two-to-two knee block, which I've had more clients say is the most uncomfortable. And so this is just kind of a process, right? A reasoning process of, do I need to block their knees or do I not? And I think that's pretty self-explanatory. Just, I think the point is, don't block their knees if they don't need it. So you always want to count when you're doing a transfer. Typically, you want to rock for momentum. Just get in the habit of doing that. There are a lot of other conditions, such as Parkinson's, that this is going to be extremely helpful to be able to do. And you're going to lean posteriorly, right, to help the client rise. And so you're going to come to either a full stand or a partial stand. Um, you don't always have to have the client come up all the way upright if they're not feeling as stable or you're not feeling as stable. A lot of times clients will stay kind of leaned over a little bit, and that actually makes it easier for you to do the pivot. And then before sitting, you always need to make sure that they are positioned with both legs touching the surface they're going to sit on. Very, very important for your safety, but also this is really setting the standard for them to eventually be able to do these transfers independently on their own. And it's really important that they've made sure they've positioned themselves to the wheelchair as safely as possible, and that they're directly in front of it before they try to sit. Then they're going to lean forward and we're going to control the sit. What I'll say is that individuals who've experienced strokes do tend to go into extension. Both when they're sitting at the edge of the bed, they want to lean back. And the problem with that is when you lean back, your bottom scoots forward. And so it's easy to kind of scoot off the edge of the bed. So you always want to make sure that sitting at the edge of the bed, they're flexed at least 90 degrees hip flexion. If you want to come forward more, then that's even better. Sitting is the same. When you go from standing to sit, you want to make sure they don't lean back to sit because what can happen is they can tip the wheelchair, right, and tip it back, or they can kind of miss it because their bottom doesn't actually hit the seat. So you want them to, again, flex forward and sit into the seat because we want that bottom in the seat, and that's what we're the most concerned about. Where is that bottom? So squat versus standing pivot transfer. So I talked about that just a little. A stand is great, but if they're not stable enough to stand all of the way, go ahead and let them stay flexed. It actually will make the transfer safer and easier for you. And then again, those are just some illustrations. So no transfer is complete until the client is safely and comfortably positioned and has a way to call for assistance. Very important. It doesn't matter if it's in the home or if it's in the hospital room. They need to have that call light or they need to have a phone. You don't leave them until they're able to maintain uh, safely where they are, whether that be sitting or in bed. Uh, some other things I would just want you to kind of keep in mind, other than just the thinking about bending forward and that squat pivot transfer, is really just consider your client, like making sure they don't grab other things when you're transferring, making sure you know where their hands are. It's always better to have more people there until you feel comfortable with a client. You don't want to take chances. You don't want to cause additional injuries. So if you have not worked with someone before, go ahead and have someone there with you as a second assist until you've been able to transfer them. Also, you're never going to leave someone even sitting at the edge of the bed, even if they seem pretty stable, because if you've had a stroke, your vision may be occluded. It's very easy. They might be sitting very stable, but if they turn their head and they lose kind of vision to that side, they can fall to the side very easy. So you're going to keep hands on them at all times until they're either lying down in the bed, sitting in the wheelchair with the seat belt, or sitting in a chair securely. And so in your OT toolkit, you have those pages. We are going to practice all of this in lab, and I'm very, very excited. And we're also going to practice cranial nerve screenings. So we're just going to go over this briefly. You guys can read the slide. I'm not going to necessarily read it to you. So when we're testing olfactory, I think it makes sense. We're going to use scents, right? We're going to use different scents, peppermint, citrus, vanilla, lavender. We're going to block the nostrils on each side and test independently. Um,